we fail. Greg Henry has told me this many times. What is the mortality in the United States in 2013?
100%.
It remains at 1 per person. So ladies and gentlemen, boys and girls, Jan Shoenberger.
Thanks, everybody. Thanks. Okay, everybody, bring your coffee in. Let's talk about death. Come on, let's do it. Let's do it. So Mel's right. I am double boarded in emergency medicine and palliative care. There's about 50 of us in the country now that are dual boarded, and this is kind of my main focus of interest. I'm also a residency director, so I'm very interested in education, and so we're going to talk a little bit about some communication skills when it comes to talking to patients about their preferences towards the end of their life. Okay, so all too often in the emergency department, we take care of patients that have life-limiting illnesses that are close to death. These are patients who have cancer, patients who have end-stage heart failure, patients on dialysis. I could keep going on and on, you know who they are. And often we need to talk to them about what their preferences are going to be as they're coming to us with symptoms and nearing the end of their life. These are really tough discussions to have, but like with most things in emergency medicine, good communication skills will get you a really long way and will often get you to the right place to do the right thing for your patient. Whether it's talking to a consultant, whether it's talking to a patient or their family member, whether it's talking to nurses, communication skills are one of the things that really make us successful at what we do. Now, unfortunately, a lot of our patients don't come in with tattoos like this, and we're not sure what their preferences are. And often we're surprised to find that this person who's cachectic and dying of cancer hasn't seemed to talk about what they want the end of their life to look like. They haven't talked about it with their oncologist. They haven't talked about it with their family member. And so it's up to us to often initiate these discussions so that their care can go the way that they want it to go and the way that you also want it to go. By the way, how many of you are thinking about getting tattoos like this? Yeah, me too. Okay, so this would be nice, but this isn't reality. So let me just add a perspective. One problem with these 3 words, do not resuscitate, is the not part. And often having conversations about end-of-life care and saying, well, we're not going to do CPR, I recommend that we don't intubate, can be really hard for a family member or a patient to hear. And so let me just share a little perspective of what that's like. This is a snippet from an article that a nurse wrote that's really nice, that explains exactly what I mean. It says, I did it twice in March 2007, once in a hospital and again in a nursing home. I signed my mother's do not resuscitate DNR form. Although I've been a nurse for more than 30 years, I'd never signed a DNR form before, and it hurt. Do not resuscitate, I wondered. What else will not be done? Will she not be nursed in a caring manner? Will her pain not be managed? What measures will be withheld? The language of the DNR order offers no answers. It's an order not to do something. Its harsh tone implies that no interventions will be performed, or worse, that care will be withdrawn. The DNR order often confuses family members, magnifies feelings of guilt they might have, and adds to their sadness. So the DNR term and the words do not resuscitate are problematic. They elicit negative reactions that may decrease appropriate end-of-life care because it brings up bad feelings, and patients and families don't want to choose that because it sounds negative and it sounds like things aren't going to be done. Many difficulties in end-of-life decisions are communication and semantic driven. It's all about the conversations, it's all about the words we choose, it's all about painting the right picture. So the words that we choose when we have these discussions really matter. We know that do not resuscitate does not mean do not treat. You know that, but do families know that? Do patients know that? When you talk about DNR, do they understand this concept? So maybe there's different words that we can choose. Maybe there's another way to look at it. So, how about the term allow natural death? How about using this term instead, or this phrase instead? So maybe your conversation should go something like this. Mr. Smith, or Mr. Smith's family member, we need to talk about something. After talking to them about their illness, painting the picture, where they are in their course of their disease, the treatments that have failed, the treatments that have been tried. If, while you're here in the hospital or in the emergency department, your heart were to stop or you were to stop breathing, the medical team who's taking care of you, we need to tell them what you want. We need to tell them what to do. One option would be that we allow you to die naturally and peacefully, like you would if you were at home in your own bed. Another option would be, if they don't choose that option right away, which often they nod their head and that's really what they want, especially the patient, another option would be, and you can describe DNR, you can describe CPR, you can describe intubation, but you need to tell them this. But it often doesn't work. And even if it does work, there won't be any new treatments that we can offer you after that. And your prognosis will be the same, or even more likely, your prognosis will be worse. Because even if it does work, after that you will be weaker and you'll be sicker than you were before. And you have to give them that reality as well. So using the words allow natural death, we're going to allow you to die naturally, is often the way that we're really trying to get them to think about things. And those words can really make a difference. Why is it better? Well, it reflects an end-of-life philosophy of providing comfort. It's a kinder tone. It reduces stress and guilt on family members and patients. It has death in the title, so actually it's probably more direct than talking about resuscitation. And it describes what will be done, not what we're not going to do, but what we are going to do, what will be done. And it feels like a more positive choice. It feels like a more positive choice to families and a more positive choice to patients. Now, there's some argument that, in fact, this phrase is not any better, and it doesn't really do much good. Why? Well, maybe it's too ambiguous. We're saying allow natural death. Well, what does that actually mean? What is and isn't being allowed if we say that? Is it comfort care only? Is it full treatment short of just CPR and intubation? It's a little bit vague. And it sidesteps perhaps a more difficult conversation to talk about exactly what kinds of things they want as they get close to death. Now, if you're lucky enough to work in a place that has a palliative care team, this is a place where they like to come down and consult in the emergency department. In my hospital, we have a great palliative care team that will come down to the ED and help you with these conversations if you need that. So that's one way to engage your specialist upstairs to come down and help you if you have that luxury. But most of us don't have that luxury, especially not at 2 in the morning. So this is a skill that we have to do, and most of us are pretty good at, but perhaps these phrases can help you a little bit. Because certainly, this is not a natural death. And this is often what people don't want, actually, but they're not really given the right choices and they're not steered in the right direction. This is certainly not a natural death. This is not what any of you would want. This is often what our patients don't want, but this is what ends up happening because we don't talk about it. What else is out there besides the allow natural death term that we could potentially use? What else is out there? Well, I want to just introduce you to the POLST if you haven't seen this already. This is Physician's Orders for Life-Sustaining Treatment. This is to complement an advance directive, not instead of an advance directive. But this really gets down to the nuts and bolts of what's possible in end-of-life care. There's cardiopulmonary resuscitation choices, there are medical intervention choices, and there are artificial nutrition choices that can be made. If you look at the top part that talks about CPR, you'll see that they describe, yes, I want you to attempt resuscitation or CPR, or I don't want you to attempt it. And you see that they use the words allow natural death on the POLST. And that's because of these reasons, that it's a more positive term that embraces really the philosophy that we're going after. You'll also see that on a POLST, it talks about the different medical interventions that are possible. Do you want antibiotics? Do you want just comfort care? Do you want IV fluids? All of these things are described, and patients can choose really what they see themselves wanting towards the end of their life. In some states, this is called a MOLST. Instead of physician's orders, it's called medical orders. And there are lots of states that have POLST now. This is a list of states that have POLST programs. There are a couple states that are called mature states. This really started in Oregon. So they've got a very mature program where you actually have a central bank of POLST that you can tap into. And there are several states that have endorsed programs. We're in California, and California ACEPT helped push the POLST through the state government, so that POLST is a legal document in the state of California, and that's true for many other states as well. Many states are on the developing list where these programs are developing, and POLST is becoming more of an option and more prevalent. So in summary, DNR can be a barrier to appropriate end-of-life care. It's got some negative connotations to it. It often makes families who already feel guilty, they don't want to choose something with not in the title. Allow natural death is an alternative way to express the idea of DNR with less negative emotion. And if you haven't seen POLST or MOLST forms or haven't heard of them, they're coming your way. Thanks.